Infinix Note 5. Is that Dr. Patrick?
Yes, yes,
Okay.
it's me.
Um, so that was my HOD in Nigeria.
Hello.
He did help me out in trying to gather some of the data. And I'm happy he's able to join us.
Good afternoon, everybody.
Good afternoon. Good
Please
afternoon.
join in.
Hello.
He did help me out in trying to gather some of the data. I'm happy he's able to join us.
Good afternoon.
Yeah. So.
So I'm going to make a start, Martins, as the colleagues from the network have actually joined us. So I'm going to give you a little bit of an introduction. So Dr. Martins Asser is a neonatal trainee working in the United Kingdom who's done his membership of the West African College of Physicians in Nigeria and actually has worked in Nigeria for an extended period of time as a pediatrician. What he will be talking to us about today is the approach to limits of viability from a developing country perspective. And in particular, he has done a fantastic piece of research which looks at the limits of viability in the different hospitals in Nigeria, which was performed approximately 12 months back, and which actually looks at different aspects of how we might be thinking of viability from a developing country perspective. So what I'm going to do is I'm going to hand over to Dr. Asso to start his talk.
Right. Good afternoon, everyone. It's good to have you all on board. We'll be looking at the limits of viability in a developing country from the perspective of Nigeria, which is one of the middle income earning countries. Most countries in Africa actually fall in this group and then in the low income group as well. Unlike in the West, we have developed countries who have had developed guidelines in resuscitation of this preterm, and they have established limits of viability, and they have guidelines on what guides them on how to resuscitate babies within the threshold of viability. Next slide, please. Fine. So just we've had about 2 lectures so far in this series, and we've talked about prematurity and the epidemiology. I will just mention 1 or 2 words and in the introduction. Then I'll talk about the fetal viability and its limits and the challenges we face in a developing country. And I'll go in detail into my study on that we'll try to look at the limits of viability, the resuscitation practices, and the survival rates in extreme preterm and the other preterm infants. To end the slide, to end the presentation, we'll do a recommendation that would stand for developing countries and as well as for Nigeria in order to develop established guidelines for this care of preterms. Next slide. So globally, sorry, I need to take this off my screen so that I can see. Sorry, Alok, I can't see the screen. I don't know what I've pressed now. Yeah, perfect. So globally, an estimated 15 million babies are born prematurely each year, and this is from data from around 2015. And we've discovered that most of these births usually occur in Asia and Africa, actually the developing nations, and it's usually a huge economic burden on these countries to taking care of this preterm, and has actually increased their under 5 mortality rate because most of these preterm have a lot of complications. And like in 2015, approximately 1 million premature babies die each year. So it's really a huge burden on the resources of the country. And if there are no funding, care of these preterm is usually a problem for most of them. Next slide, please. So, like I said, most of these preterm births occur in Africa and Asia, and India being top on the list, and Nigeria is third, and actually the first in Africa. And data are a little bit not too available, but the ones we've seen shows an incidence of 5.7 to as high as 16.8 in Nigeria, which is really, really high. So it means that there's a lot of preterm births occurring in the country, and there's really need to develop a guideline towards taking care of this preterm. And in Nigeria, prematurity is one of the leading causes of neonatal deaths in the country, and has actually contributed significantly to under 5 mortality rate in the last 15 to 20 years. The other causes are perinatal asphyxia and neonatal sepsis. Now, prematurity is actually of particular concern because it is a risk factor for perinatal asphyxia and neonatal sepsis. So, first, preventing preterm births, taking care of having an adequate program for care of preterm births will help in reducing the incidence of perinatal asphyxia and neonatal sepsis if possible. Next slide. So the survival of the premature infant is actually a function of multiple factors, and most important of which is the degree of prematurity. So we have babies who are extreme preterm, who are very high preterm, moderate preterm, and all that. So the moderate preterm is from around 32 weeks. Then between 28 weeks to less than 32 weeks is the very high preterm, and the extreme preterm, they are those that are below 27, below 28 weeks. So many factors actually contribute, but usually the degree of maturity plays the greater role. But factors such as the use of antenatal corticosteroids, which in developing countries is not easily available. There are data for it presently, but not for gestation below 28 weeks. So the practice in most centers in Nigeria and in developing countries is giving steroids at the age of fetal viability, which legally is 28 weeks. So they have an established protocol where you give steroids to mom who has gone into preterm labor or is at risk of premature preterm delivery. They give steroids from 28 to 33 weeks. But for those who are less than 28 weeks, it's usually at the discretion of the obstetrician and the neonatologist. So, which means it is not established like you want to give a mother is going to preterm, you want to give. Well, however, this varies from institution to institution. So you have some good hospitals who want to give antenatal steroids early. Again, it's respiratory support systems. The use of NIPP, the use of non-invasive mode, you want to give intubation and all that. So again, that rests on the availability of ventilators and a CPAP, which again varies from institution to institution in Nigeria and other developing countries. So you have countries, you have institutions where they don't have any form of respiratory support. You have some who have like 2 or 3 ventilators, some who have like 1 or 2 CPAP machines. So the problem actually comes from when you've got an extreme preterm infant who needs respiratory support and got stuck on the respiratory support, and then you have another preterm infant coming, and then you're able to have kind of either ventilator or CPAP for that baby. So, which means you are depriving the other baby of another cause again, which is going to increase the morbidity and mortality around this group. Again, is the postnatal surfactant administration. Until some years back, it used to be like rocket science to get surfactant and to get it administered, but at the moment, it's being given to babies. But because care is usually private funded, it's actually a problem trying to get this surfactant for these babies. So you may see a parent able to afford just one, and then maybe just a dose will be given, or at times they can't even afford it. So this really has an impact on the survival of these preterm infants. And lastly is the medical expertise. So in most developing countries, you may have, like take for instance, in East Africa, in some parts of West Africa, or you may have maybe one neonatologist in a region, or you have two in a region. And then in terms of training, they don't really have more trainees. So this has also affected the care for these preterm infants who actually need a specialist. Next slide. So what is fetal viability? So over time, the age of fetal viability is gradually reducing in terms of the gestation. So previously, from 30 weeks went to 28 weeks, came down to 24 weeks and 22 weeks, depending on the countries. For instance, in Japan, it's currently 22 weeks. So, but this age is usually set at a gestation where the extrauterine survival is equal to the risk of death, as like 50-50. And it's usually based on the survival rates of the extreme preterm infants. Say, for instance, a country that has high preterm births at 30 weeks. You wouldn't expect the fetal viability, the age of fetal viability of that country to be 28 weeks, because it means they can't serve a 30-weeker. So why do you want to resuscitate a 28-weeker? So there are really ethical issues surrounding the age of fetal viability. However, we should know that there are what we call legal limits of the viability, and then the clinical situation, which I'll go to mention later on. And it's defined as the GA at which a clinical team is required to resuscitate a baby, and when they are discouraged not to. Say, for instance, if you say it is 28 weeks, the clinician is duty bound to resuscitate that baby. And if it's 27 weeks, the decision is left for the clinician to take in consonance with the parents and the obstetrician. Next slide. So, like I mentioned, it's important to know that the legal limits of viability are not the same as the clinical issues. And for instance, the condition of the baby, if the baby comes out with no activity, you have an extreme preterm infant, 22 to 23 weeker, who comes out with no activity, no heart rate. Would you want to go ahead to resuscitate this baby? Or if the baby comes out, baby is lame but has got a heart rate, some flicker of movement, would you want to resuscitate this baby? So clinicians are basically encouraged to base this decision on the condition of the baby, the wishes of the parents, and the clinical judgment. How is this baby? What is your prognosis of the baby? Have you done a risk assessment for this baby? Now, in doing a risk assessment, you should be able to assess if a baby falls into the moderate risk, the high risk, or the what I'll call the severe risk, severe high risk, that the chances of survival is very slim and you want to palliate their baby. Or for a moderate risk, you want to resuscitate the baby. And then for the high risk, you just want to find out if you want to weigh your decisions and then want to discuss with the parents and the obstetrician. I have mentioned the legal limits of viability varies from countries to countries, and it's usually based on the survival rate of the extreme preterm. I've given an example of a 30-week, a country who has a high mortality rate for 30-weekers. They wouldn't want to consider 28-week as their age of viability. Next slide, please. So I've been in the UK for quite some time now, and I've also been in Nigeria as well. So I've seen practices in both countries. Officially, the UK still uses 24 weeks as their legal limits, but currently they resuscitate 22 plus 0 and above weeker. So, however, there are conditions you have to meet for you to be resuscitated. So, for instance, in like 2 years back, a 23 to 24 weeker who comes out and has some activity, you usually discuss with the parents on the plan forward, but we don't do cardiac compression. This has come down to 22 weeks, where you want to try to stabilize, but you won't go ahead and do cardiac compression. But in some countries, some clinicians will still go ahead and do the cardiac compression. So it's still based on the clinician judgment. But when you have an established guidelines, like in the UK, we'll have the that issued by the BAPAM guidance, the British Association of Perinatal Medicine, that seems to guide the clinician and gives them what to do in gray areas where you have like 22 to 23 weekers. So in Nigeria, the legal limits of fetal viability is still at 28 weeks. There have been discussions around this, but at the moment, the Society of Obstetric and Gynecologists of Nigeria, as well as the United Medicine, still hosts it at 28 weeks. However, babies born before this 27 completed weeks are still resuscitated based on the clinician's judgment, the parental wishes, and the conditions surrounding the baby. So, for instance, if you have an infertile couple who had an IVF, they've had like several failed attempts, and then this was successful, and they're having a 24-weeker, and they come to you, and you meet them, you counsel them, and they said, "Doctor, I want you to do everything you can for this baby." Even if the baby comes out with a heart rate less than 60, they will want you to go ahead and resuscitate the baby. And again, this gray zone is still varies from hospital to hospital. So some private hospitals will want to do their best, while some other hospitals wouldn't want to. For instance, they look at the resources available, the support for the baby postnatally, and then the complications that may really arise. So there are really medical and ethical considerations in care of these babies. And in Nigeria, it varies from institution to institution, and it's also based on the expertise and the resources available. For instance, if you have wealthy parents who want to spend every dime they have, they will want the doctor to do all his can. And as we go on, we find out in my study that most of the doctors, they look at the medical legal reasons aspect. So some parents will feel, oh, this doctor doesn't want to give this baby a chance to live. This doctor has already said this baby will not survive. How can I trust the judgment of this doctor? So again, that has an influence on their decision to limit or to carry out resuscitation. Next slide, please. So I've said about this before, the survival of preterm babies, especially the extreme preterm, poses a big challenge in resource-limited settings. So where you have like medical supplies, caffeine, oxygen, surfactant, they all have impacts on the survival of these preterms. And why disparities exist in in Nigeria, which I've mentioned before. I'll just go to my study. So having practiced in the UK, which is one of the developed countries in the world, and discovered that these countries, they have developed guidelines and published guidelines that are well circulated around the hospitals in the country that guide the resuscitation of these preterm infants. And coming from my background, I discovered that yes, we do have guidelines, we do have protocols. Some are written, some are unwritten, some are handed over from generation to generation, and this tends to guide them, but there is no uniformity. So you discover that even within the same hospital, practices may vary from one clinician to another. So I decided to do a study that looks at resuscitation practices among clinicians, both neonatologists and neonatal nurses. So what we did was a cross-sectional nationwide survey with participants drawn from level 2 and level 3 NICUs across the country. So the country has like 6 regions. So we had divided the country to 6 regions, and we picked neonatal practitioners, healthcare providers from the different regions. In our survey, we asked them questions surrounding about practice and decision making that surrounds resuscitation of this preterm infants. What will make you to want to limit resuscitation for this infant per se? And how will you want to carry out a palliative care on an infant? We also asked about the survival rates at different hospitals at different gestations. Overall, our minimum sample size was 190 participants, but we ended up sending these surveys to over 300 doctors and nurses. This study was done over a 1-year period from between 2019 to 2020, and 138 responded to the survey. So if you look at it with our minimum sample size, we actually have a response rate of 73%. And after this, 101 completed the question. So we have situations where some of the questionnaires were not complete in terms of the answers. So some will just answer half to midway and then they'll skip it. So that was also one of our limitations in the study. Next slide. So demographics, I won't waste time here. We had like 63% were females and the rest were males. Because we know the field of pediatrics is populated by females, but the males are coming up anyway. And in terms of religion, 88% were Christians and 11 were Muslims. And then you want to ask why this gap, but I will explain this in the next slide. Thank you. So if you look at the slide on region, you'll find out that the southern part of the country is almost occupying like 75%. It's 66 actually, and then you have the northern part, which takes about 1/3. And if you look at the country in terms of religion, the southern part is usually populated by Christians and the northern part is populated by Muslims. And then you have a mixed in between. The North Central also have like an equal portion of Christians and Muslims. We have some predominantly Christian areas and then predominantly Muslim areas. And again, the Northwest and Northeast is the part of the country that's currently having under Boko Haram. So it's actually war, insurgency going on there. So that may also have affected the number of responses we got from that region. So that may account for why we have a low turnout from the Muslim colleagues. And again, looking at the colleagues that we really interviewed, so 81% were doctors and then 18% were nurses. I think looking at previous studies is also quite good as well. Though we try to make it equal by sending out to almost like equal number of doctors and nurses, but these were the responses we got back. Next slide, please. So we looked at the type of hospitals. So basically we're looking at the level 2 and level 3 neonatal units in the country. Some were well established, some were not really established. And then we're also able to get to colleagues that worked in the private hospitals. The majority of responses came from those in the public, those in the government-funded hospitals. But I don't understand that some of these private hospitals, some of them are not really willing to give information for reasons I can't really hazard, but I think because probably protocol, they don't want to say things against about the institutions and all that. But this survey was actually based on individual experiences and practices, and not on the institution. Then we looked at a breakdown of the government hospitals and found that again, most of our responses came from the teaching hospitals, specialist hospital were 21%. And again, the specialists and teaching hospitals actually have level 3 NICU, so I understand why. And they tend to have more manpower in terms of doctors. And then we have like 10% coming from the general hospitals, which is basically level 2 neonatal unit. If, okay, we can move to the next slide and let's see. Thank you. So again, I wanted to ask them about if they have any resuscitation guideline. So the guideline was that talked about how you go about to resuscitate a preterm infant, what you need, how you stabilize the infant, and all that. And 74% agreed to have a guideline. 8% said they don't know if there is a guideline, and the rest says we don't have a guideline. Like I said earlier, there may or may not be guideline, but there are actually like an unwritten protocol that you tend to follow when you go to resuscitate this preterm infant. And for those who answered they have a guideline, we asked what type of guideline. So there I even discovered even within hospital, respondents were mentioning different type of guidelines. Again, that shows there is no uniformity and there tend to be no guideline being used actually. It's just what you follow. So some tend to follow what they read in the guideline by the American Academy of Pediatricians, which accounted for about 39%, while some like others were following that by the Medicine Sans Frontières. So these are just written documents. And like one actually wrote a comment that is there a guideline for preterm and extreme for preterm and term babies. So that shows there is no real protocol on ground, and that this is the document, this is what should be done, this is what we should follow. Next slide, please. So back to, we're looking at the viability, as in fetal viability. At what age will you want to resuscitate an infant? And we define that it is that age where the risk of survival equals the risk of death by 50% survival. And in some countries, it's 24 weeks, some is 26 weeks, some is 28 weeks. And I try to ask them at what would determine, what would make you to say, yes, I'll go to resuscitate this baby. And majority said both the GA and the birth weight. Of course, this has implications on the survival of the infant. So if you have a gestational age of 27 weeks against that of 24 weeks, you may be more inclined to want to resuscitate that baby with a gestational age of 27 weeks. And then 4% said others. Well, others, I mean, if baby has got signs of life. So this baby is born, it is a 25-weeker, and it's a level 2 unit, and they don't normally, they don't have the facility to care for that baby. The doctors will still want to go ahead and resuscitate the baby and get this baby transferred. So, by so they've said it's not just the gestational age or the birth weight, but rather is the condition of the baby. Next slide. So we looked at the gestational age at which most clinicians will consider from this gestation or resuscitate any baby, irrespective of how the baby is or the after doing a risk assessment, but this is acceptable gestation which will resuscitate a baby. So we discovered that there were varying responses. Again, even within institutions, there were varying responses as to the gestational age at which they resuscitate a preterm infant. So I was really happy with this response, with responses to this, because I then discovered that even at 23 weeks, some hospitals are resuscitating a preterm, are resuscitating babies. I know while I was in Nigeria then, we used to say 26-weeker, but have not participated in resuscitation of any baby less than 26 weeks. So it was, it's really shows that we are improving in our practices. We'll go on to look at the survivor at this gestation. So we discovered that majority were comfortable resuscitating 28 weekers. So resuscitated 26 weeker, 24, 23 weekers. Again, I discovered that it's actually based on some institutions and the medical expertise they have. So if they have a good neonatal healthcare professionals, have a good nurse, the nursing is superb, the doctors have good equipment, they're able to take in this baby. But the question is, how many numbers can they take? How many 28 weekers? How many 26 weekers would they resuscitate? So actually based on the expertise and the infrastructures, what the equipments they have. So overall, the median gestational age is 27 weeks. So this means the legal viability age is 28 weeks, but it's called that the median GA was 27 weeks. So it means that it will be good to review that 28 weeks, because this has actually been there for a long time, since when I was a medical student, has been 28 weeks. So actually thinks you need to review this. Next slide, please. So next is, we also ask the doctors, if you don't have the GA available, for instance, a mother didn't get a dating scan, mom could not remember her LMP, and then you have an estimated fetal weight, at what weight will you want to resuscitate the baby? For instance, a 400 grammer, will you want to resuscitate a 400 grammer? Most of our responses were from 500 grams and above. We discovered that a huge percentage, like 22%, were resuscitating babies 500 grams and above, which is quite good. Again, if you look at it with our slides, babies resuscitating at 25, 26 weeks, it's tallies. And then we look at majority, basically we're looking at 800 grams. And while I was in Nigeria, we did have some 600, 700, but I don't know of any 500 grams. And the median fetal weight was 700 grams. So it means the average neonatal specialist will want to resuscitate a baby who is 700 grams and above. Next slide, please. Then we try to look at our data from institution perspective, private and public hospitals. And we have like those who resuscitate less than 26 weeker, those for between 26 to 27 weeks, and then above 28 weeks. And we found out that private hospitals were actually still resuscitating babies less than 26 weeks, which is really good. But again, these private hospitals, from experience, they are usually big hospitals who have an established IVF center, and they tend to take care of their own babies. So it's usually babies who are born, inborn, booked babies that they usually look after. And then the other ones who tend to send those babies to government hospitals, either in utero, mostly, and so that may account for the higher number in public health hospitals. Next slide, please. So we also looked at, in the public hospitals, the teaching hospitals, the specialists, the central, and the general, as what percentage of babies we resuscitate, what percentage of respondents, of doctors will resuscitate less than 26 weeks. So strikingly, it's discovered that at less than 26 weeks, the central hospitals, they don't resuscitate, doctors in central hospitals do not resuscitate a baby less than 26 weeks. And I'm actually surprised that in general hospitals, about 4% of respondents say they will resuscitate less than 26 weeks babies. And this, again, central hospitals actually, they have more funding, they have more equipment, they have more manpower compared to the general hospitals. Again, it still shows that our hospitals, government funded hospitals, still resuscitate these babies. I know most of these level 2 centers, they just stabilize and then send these babies to the tertiary hospitals. But again, it's still advised that you refer these babies in utero rather than waiting for them to be delivered, because we still have a poor natural transport system in Nigeria. Next slide. So we looked at, this was, again, it's an individual response. So we went to look at how, for each gestation of 23 weeks, 24 weeks, 25 weeks, how frequent will a doctor want to initiate resuscitation for this infant? So if you could hover the cursor around the blue and yellow, which says is the always and often. So always and often means they will always want to do it, they will often do it. The gray ones is sometimes. So it depends on a lot of other factors. And then some say rarely, and then some say they will never. You can see 41.8% of respondents and 19. Let's say, but 60% of respondents say they would not want to resuscitate a 22 to 24 weeker. Quite a strong statement and a huge number. But as you go, you see the number reduces. So from 25 to 26 weeks is about 50%. So that means that doctors and nurses are more comfortable with 25 to 26 weeker than with 22 to 24 weeker. Again, is the survival rate of these babies. That's what will actually tell if it's not just to resuscitate these babies, again, it's to take care of them. So one of the problems I had while I was in Nigeria is, yes, we were able to resuscitate these babies. The babies tend to stay 1 to 3 days, and then they develop IVH, surgical neck, complication of prematurity, and the rest is mortality. So it's not just to resuscitate these babies, it's their survival rate, which we're able to establish to some extent, but not in details. So move to the next slide. So we look at estimated survival rates. So these were just, we asked the doctors, what is the estimated survival rate. So we're based on individual responses. So for doctors and nurses who have not taken care of a 24-weeker, for instance, now, they won't be able to answer the estimated survival rates for them. And sorry, I forgot to say, the participants would have, those who, one of the inclusion criteria is that you would have spent at least a year. So you would have spent enough time to be able to know, to understand how care for a neonate is, to know about the survival of a neonate, how your unit runs and all that. So if you look at this, the 23 to 24 weeker, discover that, so on the y-axis is the number of respondents, and on the x-axis is the estimated survival in terms of percentages. So you see how many, like for 23 to 24 weeker, is it 1 to 10% chance of survival? Is it 26 to 50% chances of survival? Is it above 90% chances of survival? So if you look at the, for 23 to 24 weeker, 50% of respondents say give 0% survival rate for them. And just around 2 to 3% were given above 90% chance of survival. I didn't include the slide, but I have a slide that showed that this distribution is more of in private hospitals. So they are better equipped. Some of them tend to have this, I'm talking about the top class private hospitals. Some of them are equipped, they are better equipped. They have the infrastructure, parents are able to fund the care. So it's usually based on a lot of factors. So if the resources are there, they tend to have good results. Now, if you look at that for 27 to 28 weeks, which is the gray one, you can see it's still 26 to 50% chances of survival. So again, it shows that from babies from 27 to 28 weeks, their chances of survival are higher. So this is an individual response. We didn't really look at the hospital data to state their survival rate, so which is also a limitation to our study. Next slide. So we want to look at ethical decisions that we want to surround, that will make a doctor to want to say, I'm not really keen on resuscitating this baby, but I want to resuscitate this baby. So we asked them generally about how factors such as probability of death, is it always, often, sometimes, rarely, and never. We asked them in that grading, so for them to grade children. So there were responses for each of these factors stated here. And further, the major factor that will make them to limit resuscitation or don't want to say is the risk of poor quality of life. So if, for instance, the baby has this baby's mom has preterm prom of from around 19 weeks, 20 weeks, and then baby had severe oligohydramnios, we have pulmonary hypoplasia and all that. So they wouldn't want to resuscitate that preterm infant. Or this baby has got some congenital anomaly, they wouldn't also want to resuscitate that infant. But most importantly, I discovered that most of the respondents say they will resuscitate an infant based on the fear of litigation. So I've also had this discussion with some of my colleagues there, and they also say, yes, there are different interpretations to practices. So we have a learned population, quite all right, but they may not understand the implication at that point in time. Going ahead with utilization is not in the best interest of the baby. So it will not be like something of compromise, but some doctors are just scared of facing litigation for medical legal reasons. They don't want to be they didn't give this baby a chance to survive. So they will want to do all they can to resuscitate these babies. And I've asked on, so if you have a baby who, like a 24-weeker is out, has some flicker movements, heart rate is less than 60, times you don't even hear the heart rate, so you will still go ahead and resuscitate this baby, because you don't have there is no established protocol guideline that guides you on this is what you do, this is what you do. Unlike we have developing countries that says you can do A and B and leave out C out of it, but it's not there. And when the parents make a complaint, in terms of having a defense would really be difficult for them. So they will want to err on that side and go ahead with the resuscitation of this infant. And the pain the infant will go through this process is really minimal in terms of having an influence on the decision to limit resuscitation. Next slide, please. So we went ahead still to ask around ethics surrounding preterm care. So we asked participants about if they've ever palliated a newborn, and shockingly, 50% says they have. The other 50 said they have not. And one of the responses was is against it. It says it's against its religion. Every person should be given a chance to live. Why should I contribute to the death of an infant and all that? So, and I went ahead to ask those who answered if they palliated an infant, and they said yes. And majority we asked questions were like, will the ET tube be removed for those that are intubated? Will the ET tube be removed in the unit? We asked them if it would be by the doctor or by the parents. 13% said yes, to be removed by the doctors. 4% said it will be removed by the parents. And then some said yes, the baby will be ambu-bagged to the door leading to the unit, and then give the baby to the parents to take home, with the expectation that the baby will die at home there. And then again, majority says the infant will not be extubated, as in they will place a ceiling of care for the care of this preterm infant. So the infant will remain tubed, be on the ventilator, or if it's not tubed, or receiving respiratory support or whatever. But care, other medications will not be given. So what majority will be given is like given like paracetamol for pain, just baseline medication, but you don't want to give something, you don't want to do something active for the baby. And then 23.4% says parent will allow to discharge the baby home with the hope that the baby will die. And then others, like if you are giving some, say parents will just, baby will not, probably baby is not any respiratory support, but baby will just be there, they will still be giving medications as it is, but just wait until baby's done. But they won't do any like investigations, do any invasive procedure or whatever for the baby. Next slide. So our study actually revealed a lot of variations in resuscitation practices by neonatal healthcare providers, and we were able to find out that our preterm babies actually constitute major clinical problems with usually constraints on the human and material resources. So these have various impacts on the economies of these countries. And just as I mentioned earlier, there's limited data on extreme preterm infants in low and middle income countries. And fetal viability is still officially at 28 weeks, and actually this needs to be reviewed. And following our survey, and from other studies I've seen online as well, they have been called for them to have a review of this official age. So we hope that this will kickstart a discussion towards the review of this age. And lastly, there will be, in having a discussion regarding this official age, there will be a need to involve all the relevant stakeholders. So this means you want to involve those who care for the mom, like the obstetricians, you want to involve them, the neonatologists through the Nigerian Society of Neonatal Medicine, the Pediatric Association of Nigeria. Of course, these people will care for the baby after the preterm in terms of the neurodevelopmental outcomes. But I want to involve the government, the Federal Ministry of Health, through their representatives. And then, like I did mention from a large, these private hospitals, we say this preterm infants. So we want to involve representatives from this private hospitals. So there will be a need for them to have like a conference and develop a framework and publish a guideline. The aim of this guideline is to have a national guideline that is adopted and used by all neonatal care providers, both in public and private sectors. Now, we may have the problem of what happens in public hospitals may be different from what happens in private hospitals, but there may be like kind of a blanket plan where covers both babies born in private hospitals and babies born in public hospitals. So in doing this, you may have a legislation by involving the legislator. So have relevant legislation that will make this like a law that all babies, premature babies, should follow this guideline and protocol. So if this is domesticated and amongst all the federating units in the country and is adopted by all institutions, irrespective of both private and public hospitals, is going to go a long way to ensure uniformity of care. Again, having a well-established transport system would really help in taking care of this baby. So as part of the guideline being developed by these relevant bodies, it should be a plan to transport a baby from whether private or public hospitals. Another issue that may come in is the funding. So there is actually a big funding gap in hospitals, both public and private hospitals. So in public hospitals, they may be lacking manpower, lacking medical supplies. Private hospitals, the parents have to pay for care. So in a situation whereby the parents may not be able to afford care, this may affect the care of the baby. So there may be some kind of a scheme that takes care of maybe babies born below 27 weeks, and that may be like some form of grant for the parents that will help them, whether you're in the public hospitals or in the private hospitals. Yeah. Next slide. Okay, perfect. So yeah, so it's open for discussions and questions, and then I'll be happy for my colleagues from Nigeria to have some inputs regarding to the practice in Nigeria. And I don't know if we've got some participants from other African countries like South Africa. I want to know the age of fetal viability in South Africa. Thank you.
Can you hear me, Martins?
Yes.
Yeah. So fantastic talk. I think an absolute eye opener for us about the challenges that we encounter in countries that are developing and middle income, and very similar to problems that we face when we're in India, where you have populations at different, I would say, levels of care. Some able to access public healthcare only because they can't access private healthcare for the cost reasons. And obviously, some parents who would obviously want to only access private healthcare because the facilities they can pay for, but would be able to cater to obviously babies with full technological facilities. And the more preterm you are, the more technology you need. So it's it's very similar in India. I think one of the things that I wanted to ask, and it might be that Patrick can also help us with answering that question, is for babies who say are resuscitated in Nigeria, it looks like from your data there is a strong drive where the parents want resuscitation, whether that's a private or a public hospital or a teaching hospital, to initiate resuscitation in those babies. But I'm sure that in public hospitals, there must be resource limitations, which means we can't carry on with care. Could you talk to me about how those babies are then managed once you start resuscitation? If you don't have the resources, but you're trying to obviously uh, support the parents, by showing that you've done everything. What are the outcomes for those babies?
So usually, one of the constraints we actually face is follow-up. Um, when you actually start the care for these babies, the parents want to do their best. They want to spend money. They are ready to sell their lands to meet up with the care. Usually, the first week is usually very good. Then, as you move to the second week, parents become fatigued. They don't want to do investigations. They don't want to pay for bloods. They don't want to pay for. They don't even want to come in to just like feed the baby and all that. So in some of them, we tend to have it's actually 50-50. So for those who don't develop complications like IVH, neck, they tend to do well, but it's still based on the gestation. So for instance, if you have a 26-weeker who probably is weighing 800 grams, and then the parents are actually able to fund the care, after like 2-3 weeks, they become burnout. They tend to lose interest because they know they'll be going back and forth with investigations, with medications, and all that. So the outcome is still 50-50, I guess, because most of them tend not to have neurodevelopmental follow-up. So they tend to leave the government hospitals. They just want to, because they know there are neonatologists in the public funded hospitals. They just want to come and receive care at that neonatal period and move over to the other private hospitals to continue care. So we may not be able to really know in terms of follow-up. But while I was in Nigeria then, there was a baby with that I think baby was a 26-weeker, and this baby was able to go through all the storms, stay with us for about 2-3 weeks, and then was actually coming for follow-up. The only issue this baby had cerebral palsy. Was a challenge to mom, but she was still determined and she was still following up. So as at last, before I left, baby was just on regular medications, was having seizures once in a while, but not that frequent. So in some, it's good.
Okay. Patrick has got his hand raised, so I'm going to ask him to comment on that.
Okay, thank you, Patrick. Is he with us? Hello, Patrick.
I think he's just coming through.
Okay.
Okay, it looks as if Patrick has had to leave. That's not a problem. I was curious. I mean, Gautam, you're on, and you obviously manage babies in a very similar kind of a system.
Hello.
India.
Yeah.
Hello. Good afternoon. Hello.
Hello, Patrick.
Yeah. So thank you very much for your presentation and for the work well done. I just have little comments to make. I have another meeting for now.
Okay.
I think I want to stress the importance of lack of funds or limitation of funds in our care here. And secondly, there are also issues with limitation of investigations. At times you want to run some tests that are not available, readily available, and even when they are available, parents cannot fund this care these investigations. Those are part of the things that should affect our practice here. So one, there's limitation of funds. That's a problem. Then also there are certain investigations we would love to do that you really can't do. But I know over there you may have access to all these, but these are part of our challenges here. Thank you very much.
So, but in how do we able to tackle this? Because this seems to be what happens in most developing countries, because there is no insurance, there's no insurance policy. Private hospitals tend to do better if parents are able to fund care. So if you have parents who have gone through IVF, they have this baby they've been waiting for about 6-7 years, ready to spend 2-3 million, in terms of like $6,000 for this kid. So would you want to say, in terms of making recommendation to the government, to have something like an insurance policy for these preterm infants?
Yes, that's a great idea. Then 30 times there are funds that are made available, more like a resource fund that the philanthropists can make available for parents to access, right? More like a revolving fund. That is one way that we can go. Then secondly, the government really can come in, get insurance policy for workers and for their staffs, so they can access this care.
Thank you.
Yeah, thank you. Please, I have to go now. I have a meeting now.
Yeah, thank you very much for coming. Thank you.
So I was gonna ask Gautam. Gautam,
Yes, sir.
yeah,
Yes, sir.
I'm keen to know because India would have a very similar system of private hospitals, public hospitals, and we know
Yes.
insurance is coming up. But
Yes.
in that setup, can I ask, for parents who can't afford care, who bring a very preterm baby, say a 26-weeker to your setup, how do you manage them?
Yes, it's actually a very interesting question because, like where I was working in Andaman previously, that was a central government institute. So even though the hospital is funded by the government, still with the available resources that we have, we were able to manage with what we were given. But still, sir, because once we tell them that the prognosis is going to be such that the child may not be able to take care of the baby, or there is a long-term requirement to be followed up in a hospital with certain disabilities that there, they are not very keen to go ahead with the treatment, or to sometimes at a particular point in care they would say that they cannot, or they have certain social issues. And now currently where I'm working in a private hospital, where money comes into the picture, where certain insurance companies cannot provide insurance to the baby, or the insurance is only for the mother. Still the when we have preterm counselings that we do antenatally, we also ask them the financial status. So at that time, sir, it is very difficult, even if the care, even if the prognosis is going to be just about okay, they might not be able to take care of the long term outcome, long term disability status. Sometimes they accept and they do give us a green light for the care to be continued, but sometimes it is difficult. So at that time, we always
Sorry, Gautam, I think we've lost you.
can do for the baby because it is scope.
So can I ask, just if the parents wanted to stop care in the first week of life, what would your approach be in the private setup? Would the parents go to a government hospital, or would they take the baby home if they did not have, say, the funding or the economic kind of ability to sustain care?
I think we've lost him.
I think we've lost Gautam. Yeah.
So,
Martins, what would happen in your setup if the parents couldn't afford care in a private setup? What would happen? Would you extubate the baby, and would the parents take it home?
so what happens in a private setup is, first, before they start they usually give the parents like, okay, you pay this money, pay this deposit, and then they start care. But if at particular point in time they can't really
Hello. I'm sorry. I think my network connection got disconnected. I'm not sure till where I was. This thing.
So
Audible,
Gautam,
sir.
yeah, we're still.
Yes.
I'm just asking Martins the approach to, say, for example, parents who can't afford private care in a
Yes.
private
Yes.
hospital for, say, a 26-week and the first week of life. Now, if they can't pay for it, the question that I was
Yes.
asking in Nigeria is what happens. So Martins was going to answer that, and then I wanted your opinion as well. So Martins, carry on.
Sure.
yeah.
Yes.
So what to do from experience, what they do is at when they are getting close, they first start to stop all this like if baby is on the tube, you have to let the parents know you're gonna take the baby off, and then you get a referral. So those babies are usually referred to the public hospitals. So if they've stayed there for like a week and then they can't fund care, the general practice what they do is to refer the baby to the government hospital. So they don't want to lose, they don't want to record mortality because if the parents cannot fund care, it's going to affect the caregiving of the baby. And no private hospitals, they don't want to put in their own resources to take care of this preterm infants. So what they do is we will refer this baby and the baby is transferred. They actually offer free transport services for them, and the baby is transferred to the next level 3 public hospital.
Okay. Gautam, what about your setup?
I think it's quite similar, sir, because in a state government or a government-funded hospital, they are not allowed to say no to any patient that walks into their hospital, so they have to give the care. And if a child, say, is born or is admitted in a private setup here, and after a point of time when their finances are exhausted or they are not able to fund the treatment, they do ask for referral to a government hospital. At that time, we do tell them the advantages and disadvantages of going or discontinuing care here, but ultimately it is their decision to transfer their baby to a government hospital. So at that time we do refer them to a government setup wherein they are there. The outcomes may be favorable at some time, may not be favorable, but this is again because of
I think we might have lost Gautam again.
Yeah.
Anna, do you have any questions for Martins?
I don't think I have any questions. No, thank you for a brilliant talk. It's really interesting. I'm a pediatric trainee training to go into neonates, so it's really interesting to sort of hear your experiences and your approach and compare it to sort of how we are taught to sort of consider these things as peds trainees in the UK. So it's fascinating. Thank you very much.
So, Anna, can I ask you a question?
Of course.
So, did you manage to do the MCQ?
No, I must admit I didn't.
Okay. So there's a very interesting scenario that you'll come across, which basically talks about the delivery of a couple from a high-income country in a low to middle-income setup, specifically focusing on resuscitation and the expectations of the parents where it can't be provided. What we're planning to do, obviously, is discuss this in a little bit more detail. There's another question which focuses on resuscitation of an extremely preterm baby born of parents from a low-income country in a high-income setup. So I was going to ask you the latter. So if you had to deal with parents who, say, were from India, who did not want resuscitation at 25 weeks, but were for some reason in the UK, their reasons being they can't afford it. Their reasons being when they go back to India, they have no facilities to look after the baby. They don't even have facilities to transport the baby back. How do you think you'd approach that?
That's a really interesting question. I think taking into account a family's financial situation, sort of prenatal counselling, and perhaps something that we don't dwell on enough in the UK because of the public health system and the fact that we just assume that it won't be a burden because the healthcare is free. But I often think actually we should give parents more of an impression of the financial burden it will have in the UK in terms of perhaps one parent not being able to work because of increased childcare obligation. So I think if there was a family who had concerns about their social and financial situation, that would definitely need to be taken into account. In realistic terms, I imagine I would definitely talk to my consultant at the training level I'm at the moment. But I do think it's something that we wouldn't be able to brush off and actually say, well, it's our obligation to resuscitate the baby, because as you said, we've got to consider the quality of life of that, if the parents can't support them in their disability.
So my worry about bringing in the financial implications, I mean, just matter of fact, would it make it more difficult for the parents? Would it make them feel guilt about the decisions that they're then having to make? And would it bring in what we call as healthcare rationing, where we're looking after adults till they're 100 plus, whereas we're not happy for financial reasons to kind of support? It's a really challenging area. But we put those MCQs in because on Thursday, what we're going to do is we're going to discuss these issues. So we're going to discuss how you approach them legally, how you approach them ethically, with a view to trying to iron out what viability means. And I think from our perspective, what I wanted to stress and what I will be talking about is that what we really have to understand is what viability means for the parents in different contexts. I mean, it might not be about the gestation in a country like India. It might be about their ability to afford things, future care. Whereas over here with public health funding, actually the right to life might be very important for the parents. And it's really getting that perspective to then try and have a discussion, get the parental frame to be able to try and guide them in the decision making. I think the one thing I wanted to highlight from Martin's study, so this is a study that we did in Nigeria that we're going to replicate in India and Kenya. And what it highlights is that there is a huge variation in practice based on setup in resource poor countries or resource limited countries, which means the practices would vary. And it might be that a private hospital is actually fearful of resuscitating under 28 weeks because it's more worried about its risk of mortality and how that will be perceived by the public. But there might be private hospitals who are actually very able to give care that is equivalent or even better to the way care is provided in the UK, but where the parents need to be able to fund that, and it is extremely expensive. So Gautam, are you on?
Yes, sir, I'm on.
Gautam, could you give Anna and me a flavor of the expenses that a parent might have to go through for resuscitation at 23, 24 weeks?
Yes, sure. So my experience would be from the place that I did my residency from, Ramchandra Medical College. It's a tertiary level 3B in NICU. We have two buildings over there. One is relatively the private side, wherein you have like a private hospital, and the other one is relatively a subsidized way. So so we do get we often go for retrievals to nearby infertility centers wherein the baby is born preterm, say 26, 27 weeks. At that time, our job as residents would be to counsel them about the hospital stay as well as also about the cost, because a surfactant would be a huge amount for any because of RDS. So a vial of surfactant, at that we were using Hervanta. So that vial costs 9 ml, around 18 ml cost 20,000 rupees. So that is a huge amount for any middle class working Indian. So 20,000 rupees for just a 10 ml or a 12 ml vial is quite expensive, and the baby would also be need intubation and invasive ventilation sometimes, or CPAP. So, and the hospital charge, the bed charge. So relatively for a 4-week NICU stay, it would come in 2 lakhs. So 1.5 lakhs or 3 lakhs.
So if I translate that for my colleagues in pounds, so
yes,
the equivalent cost for a vial of surfactant is about £200. and the cost for the stay of a week is about £3,000. Now, I'm just going to give you an idea. When I was a registrar in India, my salary per month was in the equivalent of £100 a month. So, I mean, you can imagine that if I had a preterm baby at that particular point of time.
Yes, it would be very difficult. It would be very difficult, sir.
So,
Hello.
Martins, yeah, you wanted to say something.
Yeah, one of my colleague from Nigeria, Mudiaga, is here with us. I don't know if she could just tell us something about the cost of a preterm in Nigeria.
Yep.
Mudiaga. Hello.
Not a problem. It might be that we've lost the connection. Oh, actually, she's come through. Yes.
Mudiaga. Can you hear me?
Yeah.
Yeah. So we were just looking at, thank you for coming in, looking at the cost of care for preterm infants, and we looked at that for India, and we found out like the cost for a surfactant is around £200, which is about, in Naira, it's about like 400,000 Naira or so. So would you want to just tell us what an average cost for a preterm was delivered at 26 weeks? Like, you want to use like cost in a public setup or private sector, whichever one you're comfortable with. Let's know. Thank you.
Thank you so much, Dr. Martin. Hi, everyone.
Hello.
It's not clear cost, and it also depends on the cost of care per teaching hospital or tertiary facility, but it runs in millions. Even if it's a government setup, it's also going to run in millions. And if it's in the private sector, it's going to be at least times 3 of that amount. So very good private facilities that may be able to give optimal newborn care for kids can ask you to send the deposit as much as 1 million naira if it's a single thing, or if there are multiple, maybe you may have to deposit as much as 3 million, which is really just like the startup fee. And as the child keeps getting care, you may need to make some more deposits. And probably at discharge, you will also have some balance. So it runs in millions, basically. But what I'm going to say is that it depends solely on how preterm the child is, how long the child stays, and whatever complications may rise up when the child is being kept for infertility. Thank you.
Thank you. So if I want to translate, so $1 million is about £500.
That's about that.
Yeah. No, $1 million is about £2,000. So
$1 million
yes,
is about £1,000. You're right.
yes. So for my colleagues here, you can understand how much it takes to take care of this preterm infants in Nigeria. So thank you, Gaga. Thank you very much.
Would that be the cost for a week, or would that be the cost for, say, a month?
It's online to be the cost for a week or for a month.
A week, okay.
Child is going to be on the ventilator. The cost runs weekly.
Sure.
Right? And it's when it's a government facility, the bill is in segregation, right? And it's not a clear cost bill. But if it's a private facility, it's irrespective of what aspect of care is dominated or is being negligible. All right, so you get to hear go and pay a flat sum of this, and we're going to be treating the child. And when they say that the child has been left about another 2 to 4 weeks and the cost of care has risen higher, they can come to the finance department and say you need to make some money. It can run for weeks, it can run for days, it can run just depend on what kind of care the child is going to have.
Martins, would you like to elaborate, just because it was tricky to understand what was being said?
Okay.
I apologize. Yep.
Yeah. So basically, the cost for a preterm, usually in private and public hospitals, are a bit different, but at the end, they virtually run the same because the parents will fund the care and will pay for their medical supplies in public hospitals. So that means they keep bringing out money from their pockets every now and then. But in private hospital setup, everything is provided. So they just give you a bill and you pay. So you're asked to make a deposit. And then when your deposit is running out, you're asked to add another deposit. So for instance, if you pay like $1 million this week, which is about £2,000, and you're running out, you have to make another deposit. So if you take a 26-weeker who will spend minimum of 8 to 10 weeks, you can imagine how much the parents is going to cover, which is quite much. Even me as a doctor, I don't think I can afford such an amount. And so the care is usually high, and private hospitals tend to get results, but that's for those who have parents who are really rich. And of course, if parents are really desperate to keep the baby, they are ready to sell or whatever they have. But like I said earlier, if they are running out of funds, the private hospitals will have to refer them to the public hospitals, which also reduces their chances of survival, because that period where they will be transported over, change of care, have to start again, affects their care.
That's
Yeah.
really helpful. That's kind of bringing us to the end of this session. So, what I wanted to do is just give you a flavor now of what and how to use the website. So, as of today, we've kind of covered preterm epidemiology, and we've covered viability as a kind of a concept in developed versus developing countries. What we're now going to talk about is actually ethical decision making. And we're going to cover three aspects of that on Thursday. The first aspect is obviously ethical decision making from a developing country perspective, ethical decision making in a developed country and the differences. But the website, as we're producing the management chapter, will have guidelines from every country along with a talk by their lead for the guidelines group of that country. So we've got a talk from Professor Marlowe regarding the BAPM guidance that is going to be up in the management section. Similarly, for the Canadian neonatal guidelines, we've got a talk from Keith Barrington. And for the guidelines from Sweden, we'll be having Magnus Domelov, who'll actually be speaking to us in person as well. From a developing country perspective, we obviously have a few authors who will be joining us. And the idea is to give you a flavor of countries where there is existing guidance, countries where there is no guidance, and what medical professionals do. And I think the talk that Martins has given us today has given us a very good overview of how people actually manage a situation where there is no guidance, there are no ethical kind of documents. The reason being, there is a huge spectrum of care that's being provided in different setups with clinicians who have differing practice. But what we will do at the end of that is we will discuss some of the questions that we've asked in the MCQ. So I'm not going to tell you the answers. And what I am going to do is give you an approach to those answers based on where the baby is delivering and the practice of that particular setup. So what would be very interesting is to see what we as professionals have decided based on where we're working as to how we manage those particular situations. So thank you so much for joining us today. I will be sending out a link for the talk on Thursday. Again, all these talks are available and they're recorded and they're available on YouTube. The links go up on the website. So, by all means, in 24 hours, you should be able to access this talk again. Thank you very much.
Thank you, Alok. I want to say thank you to Dr. Ilo. He was able to join us from Nigeria, though he joined late, but thank you for coming.
Thank you. I'm so sorry for joining late.
No, that's really kind, Dr. Ilo. And I think we will be in touch because we'd be very keen to have a presentation from you. So I'll be writing to you at a time of your convenience, if that's all right with you. So
it's okay.
I'm really
Thank
grateful.
you. Thank you. Thank you, Alok. Thank you. Hope we are going to get the talk so we can go through it, the slides.
Yeah.
Oh, that would be very nice.
Not a problem at all. Yeah. We will be, it'll be up on YouTube in about 24 hours.
It's okay, sir.
Thank you. Thank you. Thank you, everybody. Have a nice day.
Thank you. Thank you, Alok.
Thank you. Thank you, sir.